Hello. So let us discuss FMGE July 2024 questions. First question asked in anesthesia was 𝗂𝗏𝗡 scoring is used to assess difficulty for endotracheal intubation, orogastric tube insertion, oropharyngeal airway insertion, nasopharyngeal airway insertion. So 𝗂𝗏𝗡 scoring system, favorite topic of exam. What is 𝗂𝗏𝗡 scoring system? It is a pre-anesthetic evaluation to predict difficulty in intubation, difficulty in laryngoscopy and difficulty in mask ventilation in the order, right? So 𝗂𝗏𝗡 scoring is pre-anesthetic evaluation. So we do it in the PAC room to predict difficulty in laryngoscopy and intubation as the first answer always. Difficulty in laryngoscopy and intubation. This is very important. This is the prime reason of doing 𝗂𝗏𝗡 scoring, and also it predicts difficulty in ventilation. This is second option. If both are given in the options, that to predict difficulty in laryngoscopy and intubation and ventilation both, then I would go for that as an answer because it predicts both. But if only one is given, I would choose laryngoscopy and intubation. So endotracheal tube insertion, right? This would be the answer. We need to know few things about 𝗂𝗏𝗡 grading, which is so commonly asked in exam. 𝗂𝗏𝗡 grading, we ask the patient, how do we do it? We ask the patient to open his mouth. I will demonstrate you, right? Open mouth. So I ask the patient to open his mouth as much as possible, ah, and then take the tongue out, ah, ah, and should not vocalize. Patient should take the tongue out and should not vocalize. And then I peep inside his oral cavity and try to see the structures of oral cavity. If I am able to see all the structure, grade 1. One structure missed, grade 2. Only hard and soft palate and base of uvula, tip of uvula not seen, grade 3. And only hard palate, grade 4. So actually what is happening, this is the oral cavity. This is, let's say, the tongue out of the oral cavity, and I am seeing the structures of oral cavity. As the tongue is increasing in size, right, it is obscuring the structures of oral cavity and I am not able to see the structures. So basically 𝗂𝗏𝗡 grading is the assessment of size of tongue. It assesses the size of tongue with respect to oral cavity. Bigger the tongue, difficult would be the laryngoscopy and difficult would become the intubation, right? So it just predicts the size, just tell us grades the size of tongue with respect to oral cavity. There are 4 grades, grade 1 to grade 4, and grade 1 and 2, no difficult intubation. 3 and 4, this is predictor of difficult laryngoscopy and intubation. This is the predictor of difficult laryngoscopy and intubation. So answer is endotracheal tube insertion. Now there is no scoring system to predict difficulty in orogastric tube insertion, no scoring system to predict difficulty in oropharyngeal airway insertion, and no scoring system to predict difficulty in nasopharyngeal airway insertion. So no such scoring system available. Okay, next question. Most common intravenous anesthetic agent used for total intravenous anesthesia. So they have asked 𝗃𝗏. For 𝗃𝗏, which is the commonest combination anesthetic agent used? So many times I have taught you in the regular lecture, in the quick revision. The combination most commonly used for 𝗃𝗏 is your propofol and one of the opioid, and the best opioid which we can today use is remifentanil. Now propofol provides anesthesia, but it doesn't provide analgesia. So remifentanil is combined to provide the analgesia. So we go for a complete anesthesia with propofol and remifentanil combination. So this is the commonest combination used. So we are using propofol. This is the agent of choice for your total intravenous anesthesia. Okay, one more thing I want to tell you about 𝗃𝗏. There are some important point of 𝗃𝗏 that we need to know. You know, whatever is the benefit of intravenous over inhalational is the benefit of 𝗃𝗏. And whatever is the unique benefit of propofol, propofol has some unique benefit over all the other drug of anesthesia. Those are again the benefits of 𝗃𝗏. So let us talk about the advantages and 1 or 2 disadvantages of 𝗃𝗏. First advantage of 𝗃𝗏, that we are using propofol, right? The most common combination is propofol and remifentanil. Propofol and remifentanil. The second important point that 𝗃 decreases cerebral metabolic oxygen requirement, cerebral blood flow, and intracranial pressure. So it is good for neurosurgery. Inhalational would increase ICP. So would prefer IV, 𝗃 for neurosurgery. Third, 𝗃 maintains pulmonary vasoconstriction reflex. Pulmonary, hypoxic pulmonary vasoconstriction reflex. So 𝗃 maintains this reflex. So ventilation perfusion mismatch is less with 𝗃. So this is good for thoracic surgery. So another benefit of 𝗃. Fourth, 𝗃 maintains the dual blood supply of the liver. Inhalation a little bit affects it. So maintains dual blood supply. Of liver. So it maintains the autoregulation of blood flow in the liver. So it is good for hepatic surgery. Fifth, being propofol used as the most common agent, the drugs can be metabolized very fast. So fast metabolism both of propofol and remifentanil. So fast metabolism and recovery from anesthesia. So no residual effect with 𝗃. Then sixth, 𝗃 gives a very pleasant recovery, which is a benefit of propofol. So pleasant recovery. And seventh, 𝗃 is decreases post-operative nausea and vomiting, because propofol is an anti-emetic agent. So these all are benefit of 𝗃. 𝗃 is safe in malignant hypothermia. So eighth point would be 𝗃 is safe in malignant hyperthermia. So inhalational can precipitate malignant hypothermia. 𝗃 is safe in malignant hyperthermia. All are exam question. Now, one thing, the disadvantage of 𝗃 is that since we are using propofol, and propofol, the maintenance dose for anesthesia is a wide range of 100 to 300 microgram per kg per minute. So we need to titrate it according to the requirement of the patient. And how would we titrate? With the help of BIS monitor. The requirement can increase and decrease in a patient, and we can do the BIS monitoring, and we can titrate the dose up and down, right? We can titrate the dose up and down. Now remember this 𝗃 requires BIS monitoring, otherwise there is a risk of intraoperative awareness. So we need to be careful and do the BIS monitoring during 𝗃. And another problem of 𝗃 is, cost. It's a bit costly because it is propofol is what we are using, and it is costlier compared to inhalational if used for maintenance. So cost of the propofol and remifentanil is higher. The combination is higher. So this is the benefits of 𝗃. Okay, next question. What does ASA grade 1 means? ASA grade 1 means healthy patient. So ASA grading, so commonly asked in exam. ASA grading is used to assess the risk associated with surgery. It's done in pre-anesthetic evaluation. When we do the pre-anesthetic evaluation, the ASA grading is done. And what is done? Assess the risk associated with surgery. So we assess the risk associated with surgery. We have ASA grade 1, 2, 3, 4, 5 and 6, right? ASA grade 1, patient doesn't have any comorbidity. Patient is a healthy patient with no comorbidity. Grade 2 is patient with mild systemic disease, mild to moderate systemic illness. Mild to moderate systemic illness. Patient will have no limitation on his activity. Grade 3 is patient with moderate to severe systemic illness. Moderate to severe systemic illness. Grade 4, patient with life-threatening systemic illness. Life-threatening systemic illness. And grade 5 is different from grade 1 to 4. Grade 5 is surgery is the only option for survival. Surgery is only option for survival. So surgery is the only option for survival. And grade 6 is comatose patient for organ transplantation. So 1 to 5 is live patient and grade 6 is comatose patient for organ transplantation. Organ transplantation, right? So these are the ASA grading which tell us about the risk associated with surgery. In grade 1 there would be hardly 0.1 to 0.2% risk. Grade 2 also little, let's say 0.2 to 0.3% risk, not much difference in grade 1 and grade 2, they are kind of managed in the same way. Grade 3 the risk would increase, let's say to 6 to 10%, and grade 4 the risk would be very high. Grade 5 the risk is 50 to 60% of morbidity and mortality. So this is predicting risk, and as the grade is increasing, the risk is increasing. So A1 is a healthy patient. This is very important for exam. Next question, which drug acts on NMDA receptor? So guys, our anesthetic agents, if we discuss the anesthetic agents acting on CNS to produce hypnosis, they are mostly acting on two types of receptor, the inhibitory or excitatory receptor. So either they are acting on GABA receptor. So GABA is an inhibitory receptor, so they act as a GABA inhibitory or GABA facilitatory, or they are acting on excitatory receptor by inhibiting them, like NMDA antagonist, N-methyl D-aspartate antagonist. We know aspartate and glutamate are the excitatory receptor, so they can act on NMDA receptor as NMDA antagonist, right? So most of the anesthetic agent act on GABA receptor. So all inhalational and intravenous anesthetic act on GABA receptor. So I start writing like propofol, like thiopentone, like etomidate, they all act on GABA receptor. Your halothane, your sevoflurane, they all are acting on GABA receptor. What are the drugs acting on NMDA receptor? 3 drugs we need to remember. Nitrous oxide can act on NMDA receptor. Xenon, a new inhalational agent, acts on NMDA receptor. And ketamine acts on NMDA receptor. So these 3 agents act on NMDA receptor. So ketamine acts on NMDA receptor. Thiopentone and etomidate acts on GABA receptor. They are GABA receptor and facilitatory. Lignocaine, which is a local anesthetic, this acts on sodium channel. Sodium channel present on, they act on sodium channel, they block the sodium channel present on the membrane of the nerve fibers, sodium channel of nerve fibers. Wherever sodium channel is there, lignocaine can block that sodium channel. Okay, so answer is ketamine. Okay, next. In a cardiac arrest victim in presence of more than one rescuer, so this is one important point in the question, more than one rescuer. Now, what is the ratio of compression and ventilation? If they haven't mentioned the age group, always consider adult. The question is of adult. So they are asking more than one rescuer in adult, what is the ratio of compression ventilation ratio? So remember, for adult, irrespective of any number of rescuer, the compression ventilation ratio always is 30:2. For infant and pediatric, the compression ventilation ratio is 30:2 in presence of one rescuer, right? And 15:2 in presence of more than one person. So if more than one person coming is for rescuing, we use 15:2. If it is only one rescuer, then it is 30:2. Got it? So in adult, irrespective of any number of rescuer, the answer has to be 30:2. Now this is again a very important topic. You can refer a complete difference between adult, pediatric and infant resuscitation in the topic CPCR in our main lecture section, right? Every word of that topic CPCR is important for the exam. So for a complete information, you can refer CPCR section. Then the next question, topical anesthetic most commonly used for cataract surgery. Now this is again a very repeat question. So many times it has been used, asked in exam. Cataract surgery, which topical anesthetic agent is used? So I have taught you procaine. Procaine drops comes, proparacaine. Proparacaine. Now proparacaine is the commonest preparation of local anesthetic which is used for cataract surgery because it suits the timing of cataract surgery. Proparacaine is procaine. Procaine is short acting Easter local anesthetic. It is Easter local anesthetic, short acting. Its onset time is 4 to 5 minutes. So its effects comes in 4 to 5 minutes and the duration lasts for 10 to 20 minutes. So one cataract surgery done. So this is all the information which has been asked in exam. Okay, proparacaine. Okay, which of the following drug is used for reversal of anesthesia? Direct question, reversal of anesthesia. Now 𝗃𝗔𝗔, anti-acetylcholinesterase, acetylcholinesterase. Now this is used for reversal, but it acts by increasing the quantity of acetylcholine by stopping the metabolism of acetylcholine, by stopping the action of acetylcholinesterase. It is anti-acetylcholinesterase. So this is used as a reversal agent. Now 𝗃𝗔𝗔 is not given alone, it is accompanied with, we give 𝗃𝗔𝗔 with a antivagal agent to counteract the muscarinic side effect of 𝗃𝗔𝗔. So 𝗃𝗔𝗔 when you will give, it can increase the quantity of acetylcholine near neuromuscular junction and also everywhere in the body. So wherever there are muscarinic receptor, if the quantity of acetylcholine will increase, then what will happen? Like heart, we have muscarinic receptor, bradycardia. The secretions of the patient will increase. Bronchospasm can happen. So we give 𝗃𝗔𝗔 with the antivagal agent to counteract the muscarinic side effect. Okay. So what antivagal agent we use? We use atropine, either atropine, and more commonly we use glycopyrrolate. So answer for as a reversal agent they have asked, so answer has to be 𝗃𝗔𝗔. These are the accompaniments of 𝗃𝗔𝗔, and midazolam is an anesthetic agent, right? We don't use it for reversal of anesthesia. So answer is 𝗃𝗔𝗔. So guys, for reversal agent, we need to know few things. For reversal agents can be divided into your direct reversal agent and indirect reversal agent. Okay, the direct reversal agents, we have to remember one very important drug, 𝗂𝗪-dex. Now 𝗂𝗪-dex, what does it do? 𝗂𝗪-dex is a direct reversal agent. It stops the action, it combines with rocuronium and vecuronium and stops the action of rocuronium and vecuronium. 𝗂𝗪-dex, a direct reversal agent, it binds with aminosteroid neuromuscular blocker and can stop the action of aminosteroid neuromuscular blocker immediately by binding and taking it away from neuromuscular junction. Best it acts against rocuronium, and vecuronium. So it acts best against rocuronium and vecuronium, 𝗂𝗪-dex. If I have given a very high dose of 𝗂𝗪-dex, vecuronium and rocuronium, and I want to immediately reverse it, we can use 𝗂𝗪-dex. Indirect reversal agent is our 𝗃𝗔𝗔. 𝗃𝗔𝗔 doesn't bind with neuromuscular blocker. It simply increases the concentration of acetylcholine and assists in reversal. So this is 𝗃𝗔𝗔. Okay. So these were the questions asked. In this question, they had given that patient was given rocuronium and immediately reversal was required. Then what agent you will use? I would have answered 𝗂𝗪-dex if it was in the option. So some students on the recall, they said the question was like that, the patient was given rocuronium for intubation and intubation was unsuccessful. Immediately what should be given to reverse the patient? Answer would be 𝗂𝗪-dex. Your 𝗃𝗔𝗔 only acts at a particular time point. It cannot cause reversal at any time. 𝗂𝗪-dex can cause reversal at any time, and of any dose of neuromuscular blocking agents, right? So this is the answer here. Sugammadex is not there, so I'm answering neostigmine. Okay, so these were the questions which were asked. Okay, so let us discuss all the questions which were asked. Which of the following drug is used for reversal of anesthesia? Neostigmine. Topical anesthesia most commonly used for cataract surgery? Proparacaine. Then which drug acts on NMDA receptor? Answer is ketamine. In cardiac arrest victim, presence of more than one rescuer, what is the ratio of compression and ventilation? 30:2. And what does ASA grade 1 means? Healthy patient coming for some surgery. Most common IV agent used for TIVA? Propofol. And Mallampati scoring system is used to assess difficulty for endotracheal tube insertion. So these were the very predictable question from the very predictable topics. And if you have gone through the video lectures and if you have gone through the quick revision, you wouldn't have missed any question. You would have had a strike rate of 100%. So thank you.